I shall now introduce then our speaker for tonight, Dr. Rebecca Shakir, who is a clinical oncology consultant in Oxford, in the UK, in the dark. She graduated from Imperial College School of Medicine, which is a very highly thought of London School of Medicine, and she's a fellow of the Royal College of Radiologists. So she's done research into the benefits and risks of using radiotherapy in addition to chemo for treating lymphomas. And she's particularly been interested in trying to individualize treatment to different patients, which is really great news. So she's gained a doctorate for doing her research, and she continues to be very interested in trying to manage and reduce the risk of long-term effects and manage people who have got long-term effects, as well as active oncology management. So she helps to front up the paediatric and young adult late effects clinic in Oxford, which I'm fortunate enough to be a patient of, having been young enough when I was treated. And I first met with her about 7 years ago when we started the dream of trying to put together a survivorship plan for Hodgkin's International to make it widely available to all of you, to give you guidance and to rubber stamp what you're taking to your healthcare professionals, so you can go and say, I brought this, it's from a proper organisation, and this is what we should be looking out for. So we started the ball rolling. It was slow, but we did then pull it off. So as you all know, I hope there is a survivorship plan in there, and in fact we met recently to update it and just bring it up, make sure that it's spot on right now. So she's been very generous with her time for that, but also she's previously given us a couple of talks on Zoom. So that's wonderful. And I'm absolutely delighted, therefore, that she's agreed to come back and talk to us again. And this is quite exciting because she's talking about setting up a brand new clinic in Oxford for late effects after radiotherapy, which anybody can be referred to by anybody. In other words, the person themselves can refer themselves. And this is actually quite revolutionary. Thank you very much for being here, and over to you, Rebecca.
Brilliant. Thank you very much, Tess. And thank you everyone for inviting me. It's really lovely to speak. I think the last time I did a Zoom call with you was when I was living in a building site in the pandemic. So I'm eternally grateful that we are not in that situation, neither the building site nor the pandemic, thankfully. But yeah, thank you so much for inviting me. As Tess says, we've been working together for, I can't quite believe it, 7 years, but yeah, terrifyingly, that is how quickly time passes. And so, yeah, really, I want this to be quite, give us enough time for discussion. So I'll run through a few things on slides, and then hopefully we can have time for a really kind of useful discussion. So let me bring my slides up to you. So hopefully, she says, you can now just see my slides. Is that right?
No, but now we can.
Now you can.
Good.
Okay, yeah. Perfect. So that's just a little lag from the UK. There we go. So what I'm going to run over, and I know you all know this, but it's just helpful to kind of put things into context, is what radiotherapy actually is, what are late effects, can we treat them, can we avoid them, and what are we doing to support people with late effects? And that will be my particular focus on what we've got now in Oxford, which, as Tess says, is a really exciting step. So these are the machines we have in Oxford. So you'll all know radiotherapy is the use of high energy X-rays to treat areas of cancer, and there are cancers that are incredibly responsive, of which lymphoma is one of them. So in the UK, we're clinical oncologists, which is the equivalent of radiation oncologists in the US, but we also do chemo, but we also have medical oncologists who just do chemo. And one of the things we love saying about radiotherapy is we can cure people, which is obviously great, but there has been an increasing focus over the years, completely rightly, as what the cost of that cure is. And as we get more successful with our cures, we have those kind of late effects, of which you're all very aware. The way that we deliver radiotherapy now has, become very targeted. The technology changes rapidly. I started oncology training in 2013, and even in that time, what we can do with these machines is just coming on massively. So compared to when a lot of you may have had radiotherapy, we're really miles ahead of the way we can be quite technological with it. So I don't know if you can see my cursor, but up, let me just see, I think if I can bring a laser pointer. So up here is our kind of new machines. These are called halcyons. These are like CT scanners. You lie on the bed and go into the donut. And then these are the kind of more traditional radiotherapy machines, which do things a little bit slower, but a bit more degrees of freedom. So we can be a bit more clever with these sorts of machines that I always think look a bit like food mixers. But you lie on the bed and the patient and the machine moves around you. And then, you know, we're very targeted in what we do. So in my non-late effects work, I look after people with head and neck and skin cancer. So we're using masks like this to kind of keep people in one place. So thinking about those kind of long-term effects of radiotherapy, the word late effects is an interesting one, but traditionally in our kind of teaching, when we're thinking about radiotherapy long-term side effects, we call late effects anything that happens beyond 3 months from radiotherapy. I don't find that particularly helpful in terms of thinking about late effects, because I think it keeps things too close to the time of people's treatment and forgets the actual, you know, long-term late effects, which happen often many months, but actually many years down the line. And so when I think about late effects, I'm thinking about things that are happening, you know, months to years, particularly years down the line, particularly when people are no longer in kind of routine follow-up, so don't have access back into their oncologists. So that's kind of what we're thinking about, what I'm talking about when I'm talking about late effects. Just thinking, and don't worry, I'm not going to take us all back to A-level biology, but is important and interesting to think about why we have late effects. The way that late effects and long-term effects of radiotherapy manifest is very dependent on the dose of radiotherapy used, the area of the body treated, but the kind of biology behind it is the same principle, regardless of what organ you're talking about. So the way that radiotherapy works is that it causes DNA damage, and tumour cells in general, because they're dysregulated, they can't repair that DNA damage, so the cancer cell dies, but the normal cells that have normal checkpoints and everything can repair themselves, or the tissue has enough structure within it to repair itself even if individual cells die. And so you have a better anti-cancer effect while sparing normal tissues. But we do know that the DNA damage has effects within the tissues itself, even if the cells repair themselves in the normal tissues. So it induces an inflammation that continually has these sort of cytokine cascades, and all of those cell factors kind of sit in the tissues, and they cause new blood vessels to be made, bring in inflammatory cells, lots of tissue remodeling. And it's through that remodeling process that you get a lot of essentially scarring, collagen deposition, extracellular matrix. And that's predominantly the kind of pathogenesis behind any late effect that you're talking about, is that these tissues just become scarred over time. And it's a process that continues. So, you know, you get atrophy, so you get a kind of the bulk of the cells are sort of dying, but there's increasing scar tissue. You can get some vascular damage, you can get damage to nerves, and there's a lot of endocrine and growth effects, and these continue and continue to continue. And so it's led some people to say that radiotherapy is the gift that keeps on giving, and not in a good way, in that it's not that you get to a point where this all stops. This just continues beyond the time that you've had radiotherapy. Now, if you're a patient with skin cancer who I see when you're 90, that's maybe less relevant than if you're somebody with lymphoma, or you're a child who's having radiotherapy in their childhood years, or 20s, where you've got many decades beyond it. So that's kind of where everything comes from. In the UK, we now have these amazing consent forms. So one of the criticisms has always been from people is that, well, I didn't know this was going to happen. We talked about short-term side effects, and I kind of was aware of that, But these long-term side effects, I wasn't really aware of, or if I was, it was kind of brushed past, or it was said at a time that I didn't really have time, you know, and it in that context, it was very difficult. And these consent forms we now have for every tumour site that we will treat with radiotherapy, and they have a page going through the short-term side effects, and they have a page going through the long-term side effects. They're grouped into how likely those are to happen, and you can add notes alongside for individual people, and you can tick what that individual person is likely to expect in the future. So they're really powerful in having those discussions about radiotherapy to make sure that you bring the late effects to that discussion, but they're also really powerful for people to have in the long term, to be able to look back on and refresh once they're out of that initial, oh my goodness, I'm having cancer treatment conversation. They're a really powerful resource. So these have really changed how we talk about late effects in the UK, which is great. I put this slide in because this is so from the group where I did my PhD, is we now know quite a lot more about long-term side effects of radiotherapy. We know they are dose dependent, and we can use data from people treated in the past to try and get these what we call dose response relationships. And so what that means is we can kind of plot what the risk of a certain long-term side effect is based on what dose a certain organ gets. And predominantly this work has all been done in people treated for breast cancer or lymphoma. We have very good data sets that we use for this. And so we can predict people's risk of long-term coronary heart disease is this graph, but we're getting an increasing amount of data. And the ultimate dream, as Tess was saying, is we would really like to be able to individualize and give people, rather than just these common expected, actually say your risk from, you know, the fact that your heart is going to get 4 Gray, your kind of excess risk of heart disease is probably about this. So that we're probably going to, in the future, be able to be even more tailored into the discussions that we're having with people, which is really important when you're balancing benefits and risks. There are new ways that we can do radiotherapy. So one of the ways that we can try and reduce the long-term side effects, because we know that the higher the dose, the more likely you are to get long-term side effects, is that we can reduce the dose that we treat the normal tissues to. And the reason I showed you those machines right at the beginning is because with those new machines, the new ways of delivering radiotherapy, we can be so much more targeted in what we do. So I show you the radiotherapy plan of somebody who has a big tonsil tumour just here. And I did 2 different types of treatment for them. Right here, when he had a really large tumour, we did kind of old-fashioned radiotherapy. We needed to do this urgently for various reasons, and we've done kind of old-fashioned radiotherapy where we've bought that big Kenwood mixer head, the kind of head of the machine of the radiotherapy, and we've just used a beam where we're kind of treating from one side to the other. So you get this almost square dose. So there's colour washes where the radiotherapy dose is being delivered, and you can see that it's almost a rectangle that's kind of going through, and everything in the path is getting treatment. So yes, it's treating the tonsil tumour, but it's also giving quite a lot of the normal neck, quite a lot of radiotherapy. Once he'd got a bit better, you can see here that actually that big tonsil tumour has almost gone, which is fantastic. But we can treat the area that it was, and now we've got time to be able to plan in more detail, because we're no longer in an emergency situation. We can use exactly the same machine, but instead of just bringing it to one side, turning it on and giving a dose, we can move the machine as the radiotherapy is delivered. We can use the little collimators in the head to shape the dose, so they're little bits of tungsten that come in and out, and you can get this dose distribution where it just goes around the tumour. And then the normal bits of neck here and here, the jawbone, are not getting that radiotherapy. So we are automatically reducing the chance of this person having long-term side effects of radiotherapy, because we're sparing and not treating those areas to the same dose as we would have done. And there's been all sorts of trials in the UK, and many of these are international, where we look at how we can spare dose and what are the important structures we should be sparing dose to. So I apologize for this, it's all mainly head and neck, these sort of trials, because that's my area now of expertise. But it's the area where we do know a lot about which normal tissues we should spare to give people the best long-term outcomes. So we know that if we spare the parotid gland for people having head and neck radiotherapy, that they'll have much less of a dry mouth. That will enable them to eat much better, won't have the same problems with dental caries, and quality of life, if you don't have such a dry mouth, is significantly better. So we can do that, we can spare the parotid gland. We also know that if you spare the muscles of swallowing, so the kind of back of your throat muscles, that again, your long-term swallowing outcomes are better. Again, that has a significant impact on quality of life in terms of being more likely that you're able to manage your own nutrition, but also more likely that you're able to eat more of a normal diet than you may potentially have been able to. So there's all sorts of ways now that we can spare the organs that we believe are the things that cause the long-term side effects. So it's all really exciting in terms of what we see now in terms of long-term side effects from people treated 20, 30 years ago shouldn't be what we're seeing in the future. And then we have even different ways. So I almost said even better ways. It's not better, but we have different ways technologically of being able to deliver radiotherapy using different sorts of particles. So instead of using X-rays, using protons, so heavy alpha particles, which deliver radiotherapy in a different way. It's really important to say that they're not better radiotherapy. So the radiotherapy they deliver in terms of the anti-cancer effect is exactly the same. But because of the way that they deliver the dose, they don't have the same what we call exit dose, so the dose beyond where they deliver the dose. So they stop compared to X-rays. X-rays kind of keep on going, alpha particles stop in a simplistic form. And what that means is that you can spare. So this is again, somebody who was treated for a big sinonasal tumour, the bit in red up at the top here. When you use photons, all of this area in blue gets a low dose. When you look at protons, you're still getting low dose. It's not just around the area you want to treat, but it's less. And so that's one way as well that we can spare the normal tissues. Now, it's not all good, and I won't go into all the reasons why it's not all great, but from a person point of view, in terms of having this radiotherapy, the treatment on the right takes about 2 minutes, the treatment on the left takes about 45-50 minutes, which if you're having head and neck radiotherapy and you can't really swallow your own secretions, and you need to cough, it's quite hard. So at the moment in the UK, we don't yet do protons for everybody with head and neck cancer because there isn't any proven benefit, but we do have a randomized trial going on. And we'll see what that shows in the future. But it's one way that we can avoid. And this is particularly powerful for children. So children who have different types of brain tumours often need their whole brain and their whole spinal cord treating with radiotherapy. If you do that with a traditional photon type of radiotherapy, then often all of their organs, if you're treating them from their back, all of their organs in front of their spine get the exit dose of the radiation. If you treat people with protons, those children's heart, lungs, bowel, stomach, all of those things are spared much more radiotherapy, and that has a really significant effect. So there's some areas where protons are really, really beneficial, particularly when we're talking about children and young adults being treated. And then, there is also work going on to, well, yes, okay, we can shape the dose, but also probably we can reduce the dose completely. So I put this in just to say that there's work going, because of the long-term side effects now and an increasing awareness by oncologists of the long-term side effects, there are more and more different ways that we're thinking about how can we reduce the potential of people getting long-term side effects. And so in head and neck cancer, particularly the virus-associated cancers probably don't need as high a dose as we give. And so there's trials looking at trying to bring the dose down, which again is a really positive step. So those are all the steps and the ways that people are thinking about trying to reduce the long-term side effects of radiotherapy, which is great for everybody being treated now, but has less impact, obviously, on people who've already been treated. And there's different thoughts and ways that people are trying to treat long-term side effects. My big frustration in this area is there's really very little evidence. People don't do trials. Trials that are there where you're looking at different types of radiotherapy do not have 20 or 30-year follow-up. Follow-up stops at about 5 years, and that's predominantly because they all look at, are they better in terms of a cancer point of view, or are they better in terms of short-term side effects? Because people don't fund trials that have 20, 30-year outcomes. But to me, that's been a huge lost opportunity, that we could have been collecting information from people to understand what are the proportion of people who have these long-term side effects and what can we do to manage them and improve them. And we don't have a lot of data. This is a thing that people talk about a lot in the UK, is the red light treatment, which is sold and marketed as being able to reduce scarring due to radiotherapy side effects. And so some people use it in the acute setting to try and reduce the inflammation following radiotherapy, and some people use it in the long term, in the kind of people with long-term side effects, to try and, for example, improve neck function if you've got quite a stiff, scarred neck. And there's varying evidence as to whether it might be beneficial, but unfortunately nothing that's been done in a kind of randomized way. All the trials that show benefit were done in combination with intense physiotherapy, and it is probably the physiotherapy, if we're honest, that does the benefit. And that's where it's difficult to be able to justify making people come in 3 times a week to put a red light on their neck and their mouth, particularly if people are also trying to work, do all of these things. It's difficult to justify at the moment, given the level of evidence that we have. So there isn't a great deal of data about how we treat long-term side effects, but what we are getting much better about in the UK is how we support people with long-term side effects. And this is where I do my plug for what we now have in Oxford. Macmillan is a big cancer charity in the UK, and they have funded a few of these services around the country. So the late effects services, radiotherapy late effects services. We are lucky enough to be one of those services, and we're slightly unique in that the majority of these long-term late effects services are run by radiographers without doctor input, and we're incredibly lucky in that we have 2 doctors, 3 radiographers, and a navigator who run our service. So we are open to seeing anybody who was treated with radiotherapy aged 18 or over. That cutoff is only because we already have a service for the people younger. So it's not that we don't have services for children, it's just that they're already in a different service. And we say that people need to have finished radiotherapy at least 6 months ago. In general, once they've finished kind of seeing an oncologist, and that is really because we don't want to miss people having recurrence of cancers. We've been open since August, and as Tess says, we take referrals from anybody. So oncologists, GPs, primary care physicians, but most importantly, people themselves or loved ones. We have, children referring their parents, for example. So we're kind of agnostic about where everybody comes from. We're there for everybody, and we certainly don't need it to be people to be referred from doctors. This is us. So Jan in a suit here is a gastroenterologist with a particular special interest in the gastrointestinal long-term side effects of all cancer treatments, actually. So he also sees people just treated with chemotherapy or other agents, but also radiotherapy. And then we have Marios just here, Sinead and Mitch, who are the radiographers. they're all advanced practitioners, prescribers, trained psychologists as well, well, not full psychologists, but they have psychologist training. And so, yeah, we're a really kind of multidisciplinary team that works incredibly well together. This is some of our very initial data. So we actually opened in the end of August last year. So, but you'll see that the need was there before we were even open. We were getting people trickling in terms of being referred, but certainly since September, things have really ramped up. And when we started opening to people, we kind of did a soft launch where we did it to just internal referrals initially and check we had everything sorted. And then at the end of January, we opened to everyone, including people themselves. And that's where we had a big spike of seeing people in February. So we've had 67 referrals since we opened, 59 from professionals, 8 from people themselves. But again, that's the imbalance there is because we just did an internal opening first, just to make sure that we had all our systems and everything up and running before we got people. And yeah, we offer predominantly face-to-face reviews, but some people decide that they would rather speak to us on the phone. And these are initially the appointments are hour-long, one-to-one with one of the specialist radiographers. People are all discussed in a meeting prior to that, where we've gone through all the treatments they've had, the information they've given us, and everybody gets sent comprehensive quality of life questionnaires that we ask people to fill in before, with holistic needs assessment, so that when we come to that face-to-face meeting, we have a really good productive time in that hour, really being able to address what's most important to that person who is coming to us. As you'd expect, just from the bulk of who gets radiotherapy, most people we've seen so far have had radiotherapy to their prostate or breast, because those are the most common cancers in the UK. But we've also had people who've had treatment for head and neck cancer, for gynecological cancer, and this other includes quite a big group at the moment. Sorry, we did this very kind of just a bit of a quick and dirty, just having a look at what our referral patterns were like. But there's all sorts of people treated for various different cancers in there, including lymphomas. That late effects service that I've talked about, the kind of radiographer-led one, is a hub within a hub and spoke model. So beyond those radiographer appointments, we have lots of specialist clinics that we have ties in that we can direct and refer into for people to see. So we have a very well established sexual care after radiotherapy service, lymphedema, we have speech and language speech and language therapists, physiotherapists, a pelvic floor team, a menopause team, and all of the different specialist clinics, cardiology, gastroenterology, respiratory, who we all can kind of plug in. So we become a kind of central place where people are seen, have holistic assessment, but we can go out to all of those people for help when we need them. And then a tiny plug for the kind of aftercare service that we have for the paediatricians in the UK. Long-term follow-up for people with cancer treatment, who had cancer treatment as a child, so anybody aged under 25, has been very comprehensive for years. So this is a fully commissioned NHS service where everybody who had treatment under the age of 25 is offered long-term follow-up for the late effects of cancer treatment. And so our new service for adults runs alongside the well-established service that we run there. And that service, because of it being commissioned and there being much more comprehensive follow-up of people treated under the age of 25, we have much better recommendations for the children in terms of what we recommend in terms of follow-up. And, you know, I've put some of them here. We have very clear guidance on surveillance in terms of looking for breast cancer risk, for example, for people who had radiotherapy to the breast, or for looking for heart disease risk. And my ambition is that through having more of our adult late effects services, that we may start to be able to develop the data to give us an idea of you know, should we have a similar approach to looking after adults who were treated? The 25 age cutoff is an arbitrary one, and just what is done in the UK. But we are starting to get in the UK some actual guidelines on how we do look after and support people with long-term side effects of radiotherapy as adults. The pelvic radiation groups are the most powerful and have got the best evidence so far. So in terms of looking at the long-term gastrointestinal and sexual and pelvic floor sort of side effects. And we have these really good guidelines in the UK from the Pelvic Radiation Disease Association, which is predominantly a patient-led organisation that's brought everyone together to produce these best practice pathways, which are really fantastic. So we're already getting there a bit better about what we can do and help support adults with. And it's really exciting that we're just about to start one for head and neck. So starting to think a bit more, not just in the abdomen, thinking about other guidelines. And Emma and Sabina, who are consultant radiographers in the UK, have brought together this group, and we meet for the first time in a few months' time to start thinking about how we bring back round, how we develop some evidence-based guidelines for long-term follow-up surveillance support for people who've had head and neck cancer. I wanted to leave you, in terms of the slides, with just how powerful having these latest effects services are. And this is a very wordy slide, but I'm going to read it out to you. This is from somebody who we've seen within our clinic, who was happy for us to use her words. But when we asked, have you found the advice and support given by the late effects team helpful? She said, really helpful. Initially, it was just reassurance that what I was experiencing was very normal for radiotherapy consequences, but having dedicated time to talk openly about the problems was also so reassuring. Team provided advice on changes I can make and also suggested tests to rule out other problems. So we said, have your concerns improved since seeing the late effects team? She said, yes, to some extent with some of the changes suggested by the team, but an understanding and an acceptance that this will be ongoing and management of the issues is the way forward. And that's what she found really helpful, was that nobody had ever said before, this is what we expect. This doesn't mean the cancer's come back. This doesn't mean anything went wrong, but this is what we expect. This is what we can do to support you going forward. That is really powerful. We don't have to be able to fix things to be able to help people feel better. And that's what's the key in this area. And what we said, any suggestions that we could help improve, we said, keep going, please. There must be so many people who are suffering in silence who could benefit from this one-to-one service, and it's been so helpful. Thank you. And that's where the power, I think, of this service is. So yeah, that's enough of my voice, and hopefully gives us a good period of time to just talk and hear your thoughts and ask any questions. I'm going to stop sharing.
I'm going to unmute myself so that I can speak again. Thank you so much. That was really, I mean, massive amount of information in there, but a lovely overview. And it's really helpful that you included information about treatment modalities and how they're changing, as well as talking about late effects and so on. So somebody's already asked, do you have to live in the Thames Valley area to refer into your clinic?
So at
what's
the moment,
the criteria?
Yeah, what's the criteria? So yes, so yes, but we're relatively flexible with that. But actually, we have got a number of late effects services around us. So Bristol, Cheltenham, down on the south coast. So we kind of now know, if you're not Thames Valley, we'll refer you to somewhere that's a bit closer for you for convenience. Yeah, so it's sort of either you live in the Thames Valley or you had your cancer treatment in the Thames Valley at the moment.
Okay. Yeah, I mean, I think this whole question of there isn't a great network or it's only just developing is really important one, actually. And I you know, it's a common theme amongst the UK survivors of Hodgkin lymphoma that, yeah, you know, how do you find these clinics? And it's so patchy, it's a bit of a postcode lottery, really. And I suspect the same is true in the States too, I think, from what I see.
Yeah.
You know, it just varies from providers to providers so much.
It does. The pelvic radiation diseases website has a list of all of the late effect services in the UK.
Oh, that's good to know.
It's quite helpful, and they do keep it quite up to date. Yeah, good to kind of have a look there to see
Super.
what there might be near to you if you're UK based.
That's it. That's a good. So someone's asking, can she refer herself from London, which is sort of like
yes, but you've got 3 or 4 services in London. Yeah, depending on where you
Kate,
are.
that's your question. So there are, but so maybe the thing to do, people, is to be looking on the pelvic radiation website, and maybe that's something, Rachel, that we can do, is have a look and you know, put a link in or something onto the website so that people can go there, because there's no point in, you know, grabbing the list, because that will change all the time. But if we can put a link in that is enduring in some way, that would be really helpful, so that people in the UK can go on that and use it to look for things. Okay, there's a comment from Vanessa, who's on here. Hi, Vanessa. It's really great to see you. Shall I read it out for you, or do you want to say your own? I'll do it. Okay. So Vanessa is not a Hodgkin survivor, but she's part of our group and has been for a really long time, because she's a head and neck cancer survivor. So she says, Rebecca, thank you for sharing your work. It's lovely to see that the UK is now taking late effects of radiation more seriously. As a 52-year survivor of head and neck cancer, I'm probably the oldest survivor of head and neck cancer in the UK, having had 67 grey at the age of 12. Happy to share her experience, and I have indeed got your contact details. So if you wanted contact details for Vanessa, she says most of her issues developed 30 years after treatment, and that she has been a patient rep in the group that set up the late effects service at UCLH.
Oh, brilliant. No, thanks, Vanessa. Yeah, exactly. And that's what we need to sort of show people, is it's that long term thing that really is key, way beyond your kind of routine time of coming into hospital. Yeah,
absolutely, and way beyond the follow-up time of most of these things. Margot's saying she was treated in the UK because she grew up here, and when she's in the UK in the summer, can she come and be seen, please? I think you need to be an NHS patient probably to be seen within the service. So I think that's sadly probably a no. I'm sorry. Where do you live now, Margot?
I'm in Santa Rosa, California. Rebecca, are you interested in our experiences? Because I was treated at the Royal Marsden. I mean, I spent most of my life in Britain, so if you'd like that, I can contact you and give you my experiences. I'd love to do that. Yeah, okay, thank you so much. Thank you.
Gloria's asking about supplements like collagen or beet powder. Will that help our radiation fibrosis syndrome or our cardiac functions?
Not that we have any data to support now, no. But listen, I mean, we're open. I think this is the key, is actually we don't know about a lot of things. But no, there's no evidence for that. I mean, in general, I say to people, if you want to give things a try and they're not bankrupting you and they're not doing you harm, then it's probably okay. But yeah, there's no evidence to support that they will be helpful.
And any particular exercises or breath work that has been shown to be helpful?
No, I mean, in terms of neck exercises, there's so Emma Hallam, I saw Jill say that she met Emma Hallam, who's a fantastic radiographer working up in Nottingham, specialising in supporting people with long-term side effects of head and neck cancer. She is publishing some data, I think it's coming out, showing some really great improvement in neck range of movement and function with a combination of exercises and the red light therapy. I personally think it's the exercises that are what's doing the job, but she does some really great work in kind of neck exercises, and I can try and dig out the exact protocol of what she's done. She's hasn't shared it particularly widely at the moment because of, I think, waiting for her paper to get published, but as soon as we have that, it'll be really interesting, because I think it's initially what she did was support with a physiotherapy, but then, you know, people were taught how to do the exercise themselves and went home and continued to do them. And she's shown really great improvement in terms of neck range of movement and function improvement.
I think once that information is available, I think there's a lot of people here and that we know about who aren't able to be here today who would be really interested in that, because there's a lot of us holding our heads up around the screen. And when we all met in Boston, that was one of the really striking things. If you looked around the room, a lot of thin necks and an awful lot of us who are doing what I'm doing, which is by the end of the day in particular, we're supporting our heads because our necks aren't very strong. So that would be really interesting. Well, I'll keep in touch with you about that perhaps. And once you feel it's shareable, it would be nice to share it.
And as a shortcut at the moment, what I tend to give people is there's a lot of evidence about the neck exercises to do after you've had a neck dissection, in terms of taking the lymph nodes out of your neck to re-strengthen the muscles in your neck. I tend to encourage people to do those in the absence of any other evidence at the moment.
So if you could point me to a link for that or something, that would be really super, and then we can share that. Thank you very much. Tamara has got her hand up. Tamara, hi, would you like to state your question?
Yeah, thank you. I'm on a train here. I actually texted it, but I texted it to an individual person. So I had Hodgkin's in 1982. Mantle radiation I had in all 3 areas, and I didn't know till last year or maybe a year ago about late effects, but I've had a heart attack and on and on. So I did go to the OHSU late effects clinic, and they were great. I was there 4 hours and they gave me recommendations. Took it to my doctor, and she seems kind of skeptical or a little dismissive. And it's interesting, this whole thing about gastrointestinal, because I have issues, but I always feel now like they think I'm just a hypochondriac and it's a little difficult. So I haven't been able to find a PCP that will take me seriously. I'm not histrionic or anything. It's just, I'm now aware, yikes, I've had a lot of different things over the last 15 years, and I was completely healthy before that. Any advice there?
No, and I'm sorry to hear that, but it's a really common story that I hear all the time, and I think it comes from a lack of awareness often. Radiotherapy is not well understood in general medical kind of fields, and so the late effects of radiotherapy are even less well understood and recognized. I think we all have a role in being able to do that. And Jan and I feel particularly strongly that part of our role in this service is not only to offer support to the patients who referred to us, but also as a massive education role. And so part of the service, we have money to roll out big education days. And I think we've just got to keep doing that. But it is hard to find people who just have the expertise, I think, probably. But I'm sure that resonates with a lot of people.
Yeah. There's one quick follow-up question. You said that you're working on the late effects kind of list for adults. Is there a way you can give us a link or some way to get that information when you have it published?
Yeah, I'll share with Tess, absolutely.
Good, thank you.
Yeah, we have a lot of that information on Hodgkin's International's website. Tomorrow, I've run into that same problem of having doctors stare at me like I'm crazy for years. And I've just taken on the approach now that I have to educate them, period. I just assume that they don't know. So there's some good resources on our website. 3 docs, you can take your docs, which has our survivorship care plan, which Tess and Rebecca have put together. There's also a guideline from one of the major cancer organizations in the US, which is a really long but very thorough document on what we need to be followed for. And there's also just a testimonial letter from a doctor who was a Hodgkin survivor, who wrote about her, experience with late effects. So if your doctor is looking at you like you're a hypochondriac, send them these documents and say, look, I know it's not well known, but we need to be followed for this stuff. So take a look at it and, and then we'll talk. I've had to do that with so many doctors. It's nuts, but it really does make a difference, and they do appreciate it, because this is new. This is relatively, a new area for the medical field.
I mean,
it
it's
is.
also, we get this medication to treat, with the heart disease. We're given statins, but we already deal with fatigue. And, that's really a big problem for a lot of us.
May I move to a question from Jill? You wanted to say something, Jill Allen?
Yes, please. Rebecca, if you're still there, I can't see you at the moment. Yes, you're still there. I can see you.
It all rearranged itself.
It did do a bit of a wiggle, didn't it?
Hi. I've recently been diagnosed with exocrine pancreatic insufficiency as a late effect. Have you come across this very much?
Yeah, and yes, and Jan increasingly recognizes it. I think there's a lot of things that we never tested for, so we didn't actually realize they're not on the official list of things. But yeah, we do see it.
Right. Well, I caught up and I found in myself. I've actually seen Professor Andreev at Lincoln.
Yeah.
But I'm actually in Nottingham. That's why I saw Emma Hallam yesterday. But I'd seen 2 gastroenterologists here in Nottingham. They just said I had irritable colon, and I knew I hadn't got irritable colon because I'd lost so much weight. I'm also an ex-registered nurse, so I really had to go hard to get a diagnosis. But it took me 4 years.
Yeah, so Jan has worked with Dr. Andreev on the updated British Society of Gastroenterology guidelines, which were accepted for publication just before Christmas, haven't come out yet. But I'm pretty sure they have that all in there. So they're another thing, Tess, that I will send you once they're out.
Thank you.
But thanks for sharing, Jill.
Thank you very much, Rebecca.
No problems. Thank you.
And Jill, that's a very good case of having to self-advocate and just keep on keeping on.
Yeah, that's what I've had to do for years.
Yes. Well, I mean, I think many of us have, and I think it's one of the reasons that we've set up Hodgkin's International was to really help support people and inform them in order that they can self-advocate, because it is often the way to do it at the moment. So yeah. Cool. Are you okay for a few more minutes, Rebecca? It's 5:02 at the minute.
Yeah, that's fine.
Amanda Joshi, you've got your hand up. Amanda?
You're unmuted.
Okay, so Amanda's posted in the chat as well. I'll talk until she talks if she's going to. Oh, no, everything moved again. This is me, she says. So somebody, Margot, who's been speaking, spoke about is acid reflux or GERD a common late effect? I think most of us would say yes, it is. And Amanda followed on to that. This is me, 20 years post-radiation, and it's really bad now. Never had issues prior to this, but the radiation did hit my stomach lining and had to take strong anti-nausea meds throughout. I don't know, but I think that because if you've had mantle field radiation, of course, all the central part of your chest has been irradiated, where some rather important nerves run for the sympathetic and parasympathetic nervous system. And I think that perhaps impacts on things like reflux and so on. But I'm going to let the proper doctor talk about it now, Rebecca.
No. And yeah, probably also kind of esophageal and sphincter function, the muscle, in terms of then those all working totally smoothly, I suspect, as well.
So sort of several reasons why actually radiation of the sort of fields that we've received might well be setting that as off as a problem. Yeah. Cool. We've got Rachel.
I have a question. Do you see that radiation damages the vagus nerve and can cause GI issues, unexplainable GI issues that might be related to motility damage in the vagus nerve? Has anybody looked at it?
So people haven't looked at it, but the nerves are pretty robust, actually, much more so than gut and pancreas and things. What what we often find, what Jan always tells me, is that often people's kind of symptoms are not just one thing. There's lots of different aspects of the GI tract that have been affected. I suspect nerves probably is part of that, in terms of why people's bowels just aren't quite the same, or what symptoms they're getting. But you know, we often see lots of different things in terms of motility and bacterial overgrowth, and you know, so but you know, pancreatic, you know, the pancreatic enzyme. Somebody asked what Jill was talking about with pancreatic enzyme insufficiency, and I realized that we'd gone totally into doctor language. So sorry, it's where the enzymes don't get produced from your pancreas as much, not the ones that not the hormones that produce diabetes, but the kind of enzymes that helps your gut work and you reabsorb things from the bowel. So the reality is that it's usually not one area of damages that causes the symptoms of late effects. It's kind of a bit of everything. So yeah, I suspect it's probably, there is some nerve effects, some neural effects. It's probably on the smaller nerves rather than the actual vagus nerve itself. Big nerves are pretty robust to radiotherapy, but small nerves less so. So it is probably that. But this is where the problem lies, is that we don't fully understand why things happen. We also don't understand why some people are a lot more susceptible than others. They're likely to be individual genetic factors that we don't fully understand, but because we don't even collect who gets long-term side effects, we're way off understanding why certain people get it. And that's one of the things that I should have said actually, that Jan and I do, is that everybody who gets referred into our service, we recruit them into just a prospective cohort research study, where we're just learning from every person that we see as to why are you the person who's got all of these when your radiotherapy actually looks very similar to the next person who's just getting on and doesn't have those side effects. So we're going to try and understand a bit more about that as much as we can.
That's great. Amanda, so I'm going back to what Amanda's been on the chat, because she says her mic's not working, unfortunately, which is frustrating. So sorry about that, Amanda. So as well as, yes, it may well be that this is what, you know, that the radiation is causing the GI symptoms she's experienced. What would be the next steps, she's saying, besides informing doctors of the issues, and comments that she's also going through perimenopause, which makes it even harder to discern what's going on, of course. Yeah. So any advice at all for those people who are having upper GI symptoms like that about?
Yeah, so I think it is about trying to find a service where people understand that. So I don't know where exactly Amanda is based. Is it US or UK? But going with sort of guidelines in hand is helpful as well. When the BSG new ones come out, there is other old BSG guidelines. They're just about 8 years old now, so they're a bit out of date.
Okay.
But trying to find somebody who is sort of aware of things and can put everything together.
Kate Perry, who's in London, is on the waiting list for double valve replacement at the Brompton and is feeling very unsupported. And can you recommend anybody who could support her in London? Do you know of any services there?
Yeah, so I think the Marsden does have a service and there's interested people there. But UCLH is probably the most established late effects service. So it's probably worth have a Google, have a look on the pelvic radiation disease guidelines, which I'll have a look in a minute and find one, but and what their contact details are. So give me a minute, ask me something else and I'll have a look at the same time.
I mean, actually a number of people have been making comments about how regular exercise and yoga and things like that are helpful. So just to sort of give that a bit of a shout out, really.
Yeah, definitely.
And then Vanessa's saying that she's got to make some decisions after she's had a breast lumpectomy, or having a breast lumpectomy later this month, as to whether she should have further radiotherapy. And is there anyone in the UK who might be able to advise her, remembering that Vanessa had that huge amount of radiation to her head and neck cancer 50 odd years ago?
So I'd speak to your oncologist. Oncologists now in the UK are, you know, almost universally are much more aware and very capable of having those discussions, weighing up sort of risk and benefit. So I can't remember exactly where you're based, Vanessa.
In
I'm in
London. Yeah.
London.
Yeah. I mean, I've spoken to my oncologist. It's just whether there might be someone that's more knowledgeable. It's just trying to find the best person.
Yeah. Maybe Tess, if you put me in touch with Vanessa separately, but yeah, probably not any better, Vanessa, but we can talk.
Okay, I'll link you two up.
Until I get the results, I don't have to make that decision, but I know it's looming.
Okay.
I'm finished doing UCLH and I'm very pleased with the breast clinic there. So I'm not worried about my treatment. I just wondered if there was anyone who might have more information about the fields, because I really don't want my lungs radiated anymore. Yeah. The thing I'd say is now that breast radiotherapy is much like because we can be so much more targeted. It's much better than it used to be. It's just the reassurance I need. I just need to have more than one voice. Saying to me, Vanessa, you can do this. Yes. Yeah. No. Absolutely.
A couple of people are commenting that the risk of secondary cancers was listed as only about 1%, which we think seems a bit low.
No, you're right, but that's the only thing that we are actually really good at looking at in the UK, because all cancer diagnoses are coded and we have access to national data, so it is about 1%.
Really? It seems like it's a lot more than that if you look around our group.
But I think what is important to remember is that risk is 1% over everybody who's treated for radiotherapy. The risk is higher the younger you are at treatment, and the risk is cumulative. So the longer you survive beyond your radiotherapy, the more likely that is to happen. So in groups like yours, where predominantly people were pretty young at the time of radiotherapy, you are the group who get those long-term side effects of radiotherapy. Get the second cancers in particular. A lot of you will also have been treated with chemotherapy drugs that increase the risk of cancer. So when we talk about that 1% at 20 years, that is purely the excess risk from radiotherapy. And when we talk about the 1% at 20 years, that's the excess risk of cancer. So it's the cancer that's directly attributable to the radiotherapy. So it's not saying what percentage of people will get a second cancer, because you might have been going to get a breast cancer anyway. So it's saying compared to a population of people who didn't have radiotherapy, the excess number of breast cancers, for example, or lung cancers that you will get because of the radiotherapy. So the absolute numbers of cancers are higher than that, but some of those were going to happen anyway. What the 1% is about, the ones that are just because of the radiotherapy. Yeah. So that's why that is smaller than you see in reality, if that makes sense. And that's why statistics is really important, that you explain them as to what we mean.
What you mean by them. Yeah. Kate Perry's asking about, is there a specialist in the late effects service dealing with chronic fatigue syndrome caused by radiation? I mean, I know there is in the Macmillan service that I can access here in Gloucestershire since I moved away from Oxfordshire. So it might be worth approaching the Macmillan service, just ringing up the Macmillan helpline, Kate, and seeing if you can get some support with chronic fatigue management, because I think there is quite a lot of information about helping support people with that. Any tips beyond that, Rebecca? Or
no, again, I think it's one of those things that's really hard because it's multifactorial and it's really difficult and not well understood or looked at. So yeah, what you'll find about all the late effects services in the UK is everybody has their niche. So there will probably be somebody with that niche, and that's great. Sounds like it might be Gloucestershire, but this is why we need to bring it all together, and that's what I'm hoping. I think the pelvic radiation disease guidelines do have some stuff in about fatigue, which is helpful.
Okay. you were Googling something on that, weren't you? Or looking at something on that?
I'm looking, so I've looked at the pelvic radiation disease late effects guideline, late effects services list, and yeah, the London one is the Marsden that they list.
So Kate, that might be worth looking into.
Worth looking into.
Yeah, yeah. Okay. I'm thinking we really ought to be allowing Rebecca to go home at this point. Oh, so I think I'm going to call a halt to questions, and just say thank you so much for coming and talking to us again, and for such an interesting, informative presentation, and also for your gracious responses to lots and lots of different varying questions. So really helpful. Thank you.
No problem at all. And Tess, very happy if you collate them to just answer anything that is outstanding. But yeah, no, thank you very much for having me.
No, thank you. And I'll liaise with you about some of these documents and things that might be available to us in the future. That'd be super. Yeah. Lovely. Thank you so much. Go home and have a good evening.
Yeah, thank you so much, everyone. Take care.
Yes.
Thank you.
Bye.
Bye.